Now we have to move to this Live in a Box presentation by Jos van den Berg and Marco Manzi, ASAHI Gladius MG PV, a novel narrow looping Guidewire. This is very interesting. I have used this wire in the last weeks, Marco, and I found it very interesting, very useful.
Yeah, I agree.
Hello. In this presentation, I will discuss the ASAHI Gladius MG PV, a novel narrow looping guide wire. I will discuss the concept of this guide wire, show you some of the product characteristics and features and benefits. The concept has the purpose to expand the possibilities in very complex PTA cases. Important is that this guide wire can form a very narrow loop. It still has an excellent durability, and it's also characterized by a lasting lubricity. There are three types of the Mgpv guide wire, two 014 guide wires, and you can see the characteristics here, a long and a short flexible tip, and the 018 guide wire, which only comes with a relatively short flexible tip. Wire is available in various lengths, as you can see here. The essential feature of this guide wire is the presence of a micro gap. In the 018 guide wire, this is slightly over 10 millimeters from the tip, and the presence of the micro gap allows for a sudden increase in tip flexibility, and therefore a narrow loop can be created. The 014 guide wire has the transition zone a little bit closer to the tip, and here you can see how this really helps in forming the narrow loop instead of the wide loop that we typically see. The modified distal core makes narrow looping easier, creates a high push force, and on top of that there is the ectone with the benefits that we know from other ASAHI guide wires, protection of the core from kinking and increasing of the torque force. How can we apply this guide wire in clinical practice? As you know, recanalization of CTOs can be performed in two ways: by using a penetrating wire technique, which is rather aggressive and carries a significant risk of perforation. And then there are loop-based techniques that allow for a blunt dissection and carry a low risk of perforation. The loop-based recanalization can be performed intraluminal, where there's no problem of re-entry, and we can also use the well-known subintimal technique with a potential re-entry issue, especially in the below-knee segment. I want to finish with a case presentation, a 17-year-old male, also on the first toe of the right foot, as you can see here on the right side. Patient underwent a failed attempt with a perforation that you can see here on the right-hand side during an attempt to recanalize the anterior tibial artery. 5 days later, the patient was rescheduled, and here you can see the angiogram with a little bit of deterioration of the flow towards distal. The Mgpv Gladius guide wire 014 was first used to cannulate the anterior tibial artery, as you can see here, as a navigational guide wire. Without any problems, the wire followed the bend in the anterior tibial artery, and then the wire was advanced in a straight fashion, but given the perforation in the previous attempt, it was decided to use the loop configuration, and here you can see how easy the loop is formed in the proximal segment. Then the loop was advanced, as you can see here, towards the site of the previous perforation, and then a caravel support catheter was advanced over the wire. Good support in order to get the caravel through the occluded segment, and then contrast was injected in order to make sure that the perforation was avoided. You can see actually the perforation still present. The guide wire is now used in a straight version fashion in order to cannulate the true lumen distally. And here you can see in more detail the successful attempt of the cannulation of the true lumen towards distally. Then the guide wire was advanced towards the distality, as you can see here, using again the support catheter to provide additional strength of the entire system, and then therapy delivery with a PTA balloon catheter was easy due to the good support of this guide wire. This is the final angiographic outcome, and you can see on the right-hand side the tip of the Mgpv Gladius after all the manipulation still intact with the typical tip shape. Then this guide wire was also used distally in order to recanalize the forefoot arteries, as you can see here. Thank you very much.
Okay, thank you very much. Good morning to everybody, and thank you very much again for the kind invitation, particularly to Jos and Jihad. It's always an honor for me to participate to this great symposium. So my topic is to present a case with the new ASAHI Gladius MG PV projected and designed for a subintimal approach. This is my disclosure, and this is the case. It's about an 85-year-old gentleman with diabetes and hypertension with a constant atrial fibrillation. He is a holder of pacemaker, and he actually presents a cardiac ejection fraction quite low, about 30%. There is a creatinine serum of 1.59, and the situation in the foot is exactly what you are seeing. There is a gangrene of the forefoot in the second, in the third, with the previous amputation. The Wi-Fi classification, the Wi-Fi classification is 3, 2, 1, and the oximetry is very low. It's as you can see, 18 millimeters AG. A quite normal. This is a CO2 angiography, as you can see. So quite good patency in SFA and popliteal tract. When we analyze the below the knee situation, we can see there is a long occlusion of anterior tibial artery. This is the particular of the long occlusion of anterior tibial artery, and with a small amount of contrast medium, the selective aspect of anterior tibial is this one. So in the foot, there is a reconstitution through collaterals of the distal AT and a very subtle pedal artery. There is a fistula, an atriovenous fistula after the surgery. So quite often we can see this situation. And this is the anteroposterior projection of the foot with the contrast medium. We can see there are very, very few vessels for the toes, for the forefoot. And so in this kind of situation, we decided to recanalize the anterior tibial artery with an aggressive subintimal dissection. You can see the vessels are really calcified, and this is the Gladius MG PV 14 supported by a 4 French Bernstein catheter. You can see here the capability of the tip to be to navigate when straight, when not looped, and quite easy to be looped. You can see here how easy it is to achieve a good loop, and this good loop can be maintained very easily narrow. This is very, very important when we try to perform a subintimal dissection, especially in the Blodini vessels, which are very, very thin, when the size is not so big. And it's really, really important to maintain the loop very narrow in order to avoid possible lesions and damages on the adventitia of the vessel. You can see here in the next movie, they re-enter in the distality of the anterior tibial artery. You can see the calcium of the pedal artery and the tortuosity of the pedal artery. In this case, of course, I inserted a balloon, a short balloon. It will be a 2x40 balloon to support the wire instead of the 4 French catheter when we arrive in the foot, and we try to remove the loop from the tip of the wire. You will see I retrieve the wire a little bit inside the balloon, and then I can use the tip of the wire to navigate in this calcified and very thin vessel. Of course, the purpose is to arrive as distal as possible in this foot. We try to give the best flow, or something very similar to the best flow, towards the forefoot, because of course the destiny of this patient is to undergo a transmetatarsal amputation or an amputation of the forefoot. You can see here the small amount of contrast medium is 1.5 ml of diluted contrast medium, just to verify and to realize we are in the proper vessel, and there is an outflow towards the forefoot, so we can try to arrive to the digital vessel. You can see here the wire in the modality, in the not looped modality, how is capable to navigate inside the digital arteries. It's really amazing how the tip can go almost everywhere, and you can see this tip has been cracked, has been damaged by the calcification during the subintimal dissection. Despite this condition, this wire can still navigate in an excellent way through this very, very thin vessel. You can see here how the wire can approach the first metatarsal artery, arriving almost in the last phalanx of the toe. So after this extreme wiring, it was possible to predilate all the anterior tibial artery and the pedal artery, and arriving almost in the metatarsal artery with a very thin balloon. We choose a jade balloon from Orbus Nike, 1.5, 80 millimeters, and a 2 millimeter balloon for the bigger pedal artery and distal AT, and we achieved a predilatation with a smooth and slow inflation of the balloon, but we tried to achieve a very high pressure. Thanks to this balloon, we can arrive at 26 atmospheres, and this is a non-compliant balloon, so the efficacy versus the calcium is quite very high. It's of course important to choose the proper size. And then you can see we shorten the balloon in order to use a bigger size. After this pre-dilatation, we definitely treated the anterior with a 3 millimeter balloon, 180 in length, non-compliant, and this is the lateral view of the foot with CO2, and this is the perfusion situation with contrast medium in the anteroposterior view. After this acquisition, we took a 2D perfusion evaluation, and you can see the nice result with an improvement in density and in time of contrast medium arrival, and the possibility to perform finally a good forefoot amputation. And this is a case of last week. So in the next weeks, we will check the patient and we can follow up the wound healing process. So in conclusions, the Gladius MG PV 14 is very easy to loop. The loop remains always narrow and safe, so the probabilities to have damages versus the adventitia are very, very, very few. It has a high navigation capability when the wire is not looped, and to conclude, the tip is really resistant and durable. Thank you very much for your attention.